Is lower gastrointestinal bleeding just a bloody pain to manage? Hi, it's Dr. Fan here. Let's talk about hematochezia. Hematochezia is just another word for bright red rectal bleeding. This is the most common cause of lower gastrointestinal bleeding and spontaneously resolves in around 80% of cases, but has a mortality rate of around 2%. The most common causes of large volume rectal bleeding are diverticular disease, hemorrhoids, and colon cancers. Other causes of bleeding include colitis, fissures, polyps, angiodysplasia, and ulcers. Patients with rectal bleeding can present with symptomatic anemia, which includes symptoms of presyncope, dyspnea, lethargy, and fatigue. Large volume bleeding can also present with signs of hemorrhagic shock, which include tachycardia, hypotension, and orthostatic hypotension, which is a drop in blood pressure from sitting or lying to standing. Initial management of large volume bleeding involves acute resuscitation. This involves volume resuscitation using blood products. Crystalloids, such as saline, can be used whilst waiting for blood products, but the best outcomes occur with the use of blood replacement and correction of coagulation factors. Universal O-negative blood may be used initially whilst awaiting for a cross-match. For more information, please watch my video on massive transfusion protocol. Investigations include blood tests performed at the time of the initial resuscitation. These include a full blood count, lactate, electrolytes urea creatinine, calcium magnesium phosphate, coagulation profile, blood cross-match, and a venous blood gas. It is important to note that the initial hemoglobin may not be low in an acute bleed because there has been insufficient time for the blood to dilute to a lower concentration. However, lactate is likely to be high due to hypoxia from insufficient blood volume and blood flow to cells, switching to anaerobic respiration to compensate, which then produces lactate as a byproduct. To improve hemostasis, coagulation factors need to be replaced, along with calcium, which is important in the clotting cascade. Once the patient is stabilized, the next investigation to perform is generally a CT mesenteric angiogram, which is done to localize the source of bleeding. For this to be localized, a rate of 0.5 mils per minute of bleeding needs to occur. Once detected, the source of bleeding can be treated with angioembolization, which involves an interventional angiogram and injection of various sealants such as gel foam, particulates, coils, or glue to seal the bleeding vessels. This method is particularly effective against diverticular bleeds, where select terminal branches are the cause of bleeding. Another test for confirmation of bleeding is a nuclear medicine red cell scan, which detects bleeding at rates as low as 0.1 mils per minute. This, however, does not localize bleeding well and is rarely used in clinical practice. A colonoscopy or proctoscopy may also be performed to localize the bleeding. This is particularly effective for hemostasis of bleeding from hemorrhoids and polypectomy sites, which are amenable to endoscopic interventions, such as adrenaline injection, electrical coagulation, or mechanical clipping. Occasionally, a large volume bleed from an upper gastrointestinal source with rapid transit may cause bright red rectal bleeding, so an esophagogastroscopy should be considered if upper gastrointestinal bleeding is suspected. Please watch my video on upper gastrointestinal bleed for more information. As mentioned earlier, the bleeding stops spontaneously in the majority of cases, which means that once the patient is stabilized, we can just monitor progress with a stool chart and assess for further bleeding. Diet should then be gradually introduced once there is clinical improvement and no further concerns of bleeding. If there is ongoing bleeding and the source of bleeding is still not determined, then an operation may be required. We can attempt to localize again with an on-table enteroscopy to assess the bowel for bleeding. However, this rarely offers more information and a resection will be required to save the patient. Given the most likely remaining source is colonic, the operation of choice should be a subtotal colectomy, which removes the entire colon but leaves the rectum. In the acute setting, The remaining small bowel end should be brought out as an end ileostomy, but may be rejoined to the rectum later once the patient's condition improves. Well, I hope that you have learned something new. Please listen to this again to reinforce your learnings, because repetition is a key part of learning new information. And please remember to like, subscribe, and share and comment for more videos.